Hi everyone, I'm Ashley Bassett.
And I'm Catherine Logan.
And welcome to the Sports Docs podcast. On each episode, we chat about the most recent developments in sports medicine and dissect through all the noise so you know which literature should actually impact your practice. Today, we're coming to you live from the American Orthopedic Society for Sports Medicine annual meeting in Nashville, Tennessee.
The AOSSM annual meeting is the premier sports medicine conference each year, hosting over 3,500 attendees with hundreds of poster and paper presentations, exhibitors, and instructional course lecturers. This year proved to be as spectacular as years past. We were fortunate to have the opportunity to catch up with many of the presenters at the meeting and get their take on some of the hottest topics in sports medicine.
Over these 7 episodes, we're going to be exploring some cutting-edge sports medicine with these experts who are presenting at the AOSSM annual meeting. Are you an early career orthopedic surgeon or fellow eager to expand your expertise? JRF Ortho has some exciting news. Starting early in 2026, JRF Ortho is launching a quarterly traveling fellowship program designed to provide you with hands-on exposure to osteochondral allografts, meniscus, and ligament repair, all in a dynamic and stimulating hands-on environment.
Each fellowship will be led by distinguished faculty with opportunities to learn in different regions across the U.S. Fellows will also get an exclusive behind-the-scenes look at tissue processing with tours at our partner facilities in Denver.
Every quarter, 3 outstanding candidates will be selected for this unique experience, and one of those quarters will be dedicated entirely to an all-female cohort, with both faculty and fellows coming together to advance women in orthopedic surgery.
Applications open this September for the winter program, which kicks off in January. Keep an eye out for details and the application form at jrfortho.org and on social media later this summer. Want to learn more? Reach out to marketing@jrfortho.org. JRF Ortho, restoring movement together.
Hey everyone, before we dive in, we've got to give a quick shout out to AOSSM and their Sports Docs program. Such a great partnership and honestly something we've been really excited about since we began working together 3 years ago. Also, if you're in sports medicine, and if you're listening to this, you probably are, you've got to check out their virtual team physician series at sportsmed.org. It's packed with everything you need to keep athletes of all ages performing at their best, on the field or off. I've checked it out myself, and it's really a game changer. All right, let's get to today's guest. Jorge, Robert, thank you so much for taking time out of your busy schedules to be here with us today, the Sports Docs podcast, recording live from the AOSSM annual meeting in Nashville. Thank you so much.
Thank you so much for having me, Ashley and Catherine.
Yeah, it's a pleasure to be here.
Thank you, guys. So be easy on us. We've talked on our show a lot that neither of us do hip, so we always have to do a lot of studying for our hip episodes, so be easy on us. Okay, so today we're talking about the management of symptomatic hip dysplasia. Specifically, we want to dive into optimal treatment for borderline hip dysplasia, controversial in the hip preservation world. So as far as before we get into that, we do want to step a little bit back and talk about patient presentation and symptoms. So Jorge, how does a patient with symptomatic hip dysplasia or instability typically present, and how does that differ from FAI?
I think that's one of the main challenges, right? Because when you get one of these patients, they feel pain. It's not like a shoulder instability where they dislocate their shoulder, right? This is micro instability. So for the most part, what we see is pain. And people come and say, my groin hurts. And it's really difficult. It's really rare that a patient will come and say, I feel this like subluxation episodes. It's not very common. And it's usually a patient that you start to worry about when they come into a room and you see it's a dancer or somebody that does something with high abduction, internal rotation, and things like that, where you start to worry about this. So for the most part, it's pain, and that's one of the main complications that we have in diagnosing this. How much of this is actually instability versus impingement, right? Or labral tear and impingement kind of a thing. And that's where I think in this case, more than any other things, getting x-rays, multiple x-rays, CT scans, MRIs can help you determine more or less. And also a very good physical exam. There's multiple tests that you can do to try to evaluate that. But certainly these patients come with pain. So that's where the difficult part of this comes into play.
Yeah.
Yeah, I liken it to sort of the, posterior glenoid labral tears, right?
Yeah.
And so it's not instability, it's pain, right? So if you have a weightlifter that bench presses and they're going to have pain, in the posterior aspect of their shoulder, it's like that for the hip. When you talk about FAI, they can also have more diffuse pain too. It's not always just that deep groin pain. They can have altered biomechanics, so they have some gluteal symptoms as well, where they don't have a gluteal tear because it's a young patient. So it's really sussing that out and seeing, if it's sort of deep in nature, it's not tender palpation when you're, palpate the gluteal musculature and tendons or the hip flexors, and then you're really sort of getting to the FAI. But then, as you said, we get into some micro instability, and I know we're going to talk about that a little bit further here. But then it gets a little bit trickier too, is exactly how you're correlating those symptoms with their radiographs and everything.
Sure.
Now, Jorge mentioned a really good physical exam, so we like to talk a little bit about that. So, Robert, what are you doing on exam? What kind of provocative tests are your go-to to kind of determine symptomatic dysplasia?
Yeah, so I'll do typical range of motion examinations. So I'll obviously get them supine on the table. I'll flex them up, or before I do that, actually, I'm palpating the ASIS, use that as my lighthouse. And I'm coming down, I'm palpating the hip flexors to see, do they have hip flexor pain? Now, is it isolated hip flexor pain, hip flexor tendonitis, or do they have a combination? Do they have FAI and they have some hip flexor? Palpating the TFL and palpating down along the ITB, also the gluteal musculature and the gluteal tendons to see if they have any issues there. Sometimes they're going to have SI joint pain. Sometimes they're going to have symphysis pain. Why? Because if you have altered biomechanics because of a cam defect or even a combined defect, you're going to distribute those forces into the symphysis or into the SI. And as we know, the SI and the symphysis, they don't want to move. So the SI and the symphysis, they're stable, tight joints. And so any sort of altered biomechanics through an impingement scenario from a biomechanical standpoint, that can cause some symphysis pain or some SI pain. But anyway, so I'm going to flex them up. I'm going to see if they go to 90, 95, 100, 105. When does that pain start? And many times they'll just have pain with straight flexion. And then when I get some flexion, I'll do an internal rotation, see how much they internally rotate. Now they're going to have decreased internal rotation, typically in an FAI scenario, with cam being the most common defect that we see. So maybe they'll be 10 degrees or less, and then they'll do an external rotation. Also, they can have version issues as well. That's going to inhibit their internal rotation and contribute to their morphology. And then I'll do the flexion adduction, the fader, the typical impingement test. And then I'll do what Larson described, and I'll do a dynamic test. I'll do a dynamic internal rotatory impingement test. And so I'll get up there and I'll just rotate and dynamically rotate them in, and that's going to typically cause some significant pain with fader. I'll do a dynamic external rotatory impingement test as well to see if they're impinging posteriorly. And then I'll do some tests for instability. And so I'll extend the hip, externally rotate it, and then I ask, where's the pain? Because many times, if you're flexing them up, you do a fader, and they say, they're apprehending, where's your pain? Sometimes it's lateral. Sometimes it's right over the gluteal tendon, so they don't have that groin pain when you're doing the fader. So I just ask them to localize where your pain is coming from.
Jorge, anything to add as far as the physical exam?
So not too much to add. I would say for instability, there's three main things that I look at. One is, this is very, very well linked with the anteversion of the hip, right? So if you put him prone and the internal rotation is 70, 90, then you have to start thinking that this might be a problem. Remember that a lot of the instability cases that we see are related to version, right? So it's not just a version on one side or the other, it's a combined version that matters. So if both are anteverted, right, the chances of instability are very high. So if I put them prone and they have 70, 90 degrees of internal rotation, I'm very worried about that. And then the second thing is the favor that we described originally for impingement is a very good instability thing, right? Because you put them out and the hip tries to dislocate from the front. So the favor is important. And then the final one is a hyperextension test. You put them prone, you take their knee up, and then as the hip tries to dislocate forward, it's the same thing as the provocative test in the shoulder.
Right.
So if you do the Faber, again, I ask them, where's the pain? Because if you're doing the Faber and the pain's anterior, then you're talking about microinstability. If the pain's posterior, you're talking about ischiofemoral impingement. You have different issues with the same test. And Jorge is exactly right. It's not just the femoral version. You have the acetabular version, which is an issue, and it's the McKibben index. So we calculate the McKibben index to see what's your combined version with your acetabular version and your proximal femoral version. Because if you have a acetabulum that is neutral or even sort of retroverted, let's say, you're impinging anteriorly or superior and anterior because you're relatively retroverted. You're not completely retroverted, obviously, but you're relatively retroverted in your acetabulum. So why is that important? Because you don't want to do a superior anterior acetabular osteoplasty or rim trim in that case, because you're going to create global instability because you're already undercovered. So if you imagine if you have your acetabulum, it's supposed to be like this and it's relatively retroverted like this, you're less covered posteriorly here. So you don't want to trim here. You're going to create global instability. What does that patient need? That patient needs a reverse PAO. They need a PAO that's going to antevert them.
Yeah.
And so, so it's important to know these things and to be considering that.
Yeah, for sure. So we're going to talk a little bit about imaging. And, there's lots of different radiographic signs that indicate hip instability. Part of my interest in asking you, Jorge, is you've trained at multiple places. I know you did multiple fellowships, and we were at an AOS, and I remember you commenting on, how you see different techniques and, really how you've kind of put that all together. So can you chat a little bit about what do you do for imaging, why, and how has it varied across your training?
I think that most people have some consistency in imaging now. I think getting multiple views of the hip actually help, not to see just the lateral center edge angle, but also the anterior center edge angle. That's on X-ray, but that's a surrogate for things that are 3D, right? So now we have better technology. We have MRI, we have 3D CT scans, we have potential variations that we can do with AI and try to understand how much coverage do we have, where is the deficiency, what's the, the version, the combined version, and all those things can give us a much better idea. So if you are not fully confident that this is an impingement case and there might be some instability, I go with the full thing, right? I go with the CT scan, the MRI. We get this hip mapping thing, which I think is very helpful to make you understand some of the things that you can't see, right, on X-ray, or understand or kind of like infer from just you looking at the X-ray, right? So X-ray plus the physical exam and sometimes MRI, CT scans is what I get mostly in people that have instability.
Yeah, makes sense.
Yeah, I completely agree. And there's so much that we can gather from the X-rays, though, initially. And so that's why you have many patients that come in with just an MRI, and I'll say, no, we need X-rays here. Because, we're talking about instability or borderline dysplasia. We're typically, and you look at the literature, they're talking about a lateral center edge angle about 18 to 25 or 20, 25 in that area. And that really is not sufficient. And so, meaning you have to look at the anterior center edge angle. So you need a false profile view in all these patients. You need to look at the fear index, whether you're calculating it or whether you're seeing if your lines converge or diverge laterally, whether it's going to be impingement versus a dysplastic picture, because your physis in the proximal femur is going to form and develop perpendicular to the force vector. And so if you have some dysplasia there, your physis is going to form almost more parallel to the floor. And so you're going to have a diverging fear index and lines that's going to speak to maybe a dysplastic picture. So it's not just a lateral center edge angle. And we can calculate and we can figure all these things out just from radiographs. And so that's why I'll get AP pelvis, standing AP pelvis. I'll get a done view, so 45-degree done. And the Boston Children's Group looked at this very closely. And you can look at that entire cam lesion just by getting your done and your frog leg lateral. And you can evaluate exactly where you might have that cam or in your acetabular morphology.
I think one thing that it's important to say now, and a lot of people that may be listening to this are not, very proficient in hip arthroscopy. It's important to have a very good standing X-ray. Yeah. Because that can change measurements quite a bit, right? Yes. So a bad X-ray can make somebody feel, somebody look retroverted or dysplastic, and then when you get a normal X-ray, they're normal, right? So always make sure that has been described multiple times to read those, and never accept a bad image because your decisions will be on you, right? You can't say, well, but the radiologist said this or that, right? Or the image is not great. You have to send them back, get a perfect AP pelvis, and then you can make your measurements. If not, everything can be unreliable.
It's like the perfect lateral in the knee. It's like the Grassi view in the shoulder. I mean, it's the same thing in the hip.
Too important.
Yeah. So now we want to talk a little bit about treatment or management of people with symptomatic hip dysplasia. So there's been a lot of studies that have linked FAI to development of hip arthritis, and people suggesting that doing surgery to correct that may mitigate that development of arthritis. There has also been some studies that have linked dysplasia and shown that PAO can reduce that risk. So given this literature, are you still proceeding with non-surgical treatment for everyone, giving them a course of conservative treatment, trying to avoid surgery, or are there some people you might push towards surgery given imaging findings or exam findings?
So some people will improve with non-surgical management, physical therapy. So certainly non-surgical management, initial physical therapy is a mainstay of my practice. For how long that I think becomes challenging exactly. Is it 6 weeks? Is it 3 months? How long is that? Because as you said, we know the natural history of FAI. FAI is going to lead to early onset of arthritis. We can talk about degrees of CAMs and all this stuff to see how fast that might develop, and I discussed that with patients as well. But non-surgical management is certainly a mainstay. Also, insurance is going to make sure that I send them to physical therapy, and they're going to make sure that we have all of those visits that we're sending into them and all that stuff, right? But and then with these pictures, you might want to get an intra-articular injection too. So not a therapeutic, but a diagnostic. So you're not injecting corticosteroid, you're injecting the lidocaine. And you're seeing during a physical dynamic examination, are their symptoms improving? So if you're going to inject that like any other place you'd inject, right? Yeah. If you inject it inside the hip joint and their pain is intra-articular in nature, it's going to be relieved, momentarily or for a short-term period. And so now you have more confidence that pain is intra-articular. But it's tricky with the management of these two when you move forward and when to do it, because you said we know the natural history. Sometimes you even have a combined, and I like to remind people all the time, you can have an impinger who has borderline dysplasia. And so if you have typically a male, large cam defect, let's say it's about 65, 70 degrees, who might have a lateral center angle of 20, an anterior center angle, same thing of 18, let's say, but that's an impinger. Yeah. His issue is not instability. His issue is still impingement with his large cam. So. Yeah.
Absolutely.
Yeah, for the most part, the same thing. I would say that I never tell patients that they should have surgery. I tell them, my job is to give you information for you to make good decisions, right? So I tell them you can go with non-surgical treatment for as long as you want to. And you will come back and say, I'm frustrated with this, my symptoms haven't improved. And then at some point, this is not a life of death surgery type of thing. So you can have it whenever you want to. It's a comfort and pain type of procedure. And in the borderline dysplastic people, there's another layer of complexity, because in the impingement patient, I treat because we know the natural history will improve, right? We know that we can change that to some extent. In the borderline dysplastic, that data doesn't exist. And the second thing is that a lot of these people are dancers or are people that need the increased range of motion. So sometimes we combine these procedures with PAOs, and it's important that they understand that they may lose some range of motion. So you have to be a little bit extra careful with these patients that may have some instability. There's multiple studies that have shown now that you can achieve MCID when you do a hip arthroscopy in the borderline dysplastic. But I would say there's two things that I mainly look at before I treat them. One is the version. So if they have a combined version that it's pretty high, so a lot of antiversion, or if they have a positive fear index, those are the ones that I would not do arthroscopy alone.
Yeah. Well, Robert briefly mentioned diagnostic injections. So we did want to talk about, in the vein of non-operative, is there any role for doing corticosteroid or a biologic? So Jorge, what does that play in your practice?
It plays a role for people, usually people that have some arthritis. I would be more aggressive with injections. And then for younger people, just as Rob said, mostly from a diagnostic perspective, if I'm not sure where the pain is coming from. That's to convince me and the patient, right? If we say, it's like a firefighter in a house. If you go to the wrong room where the fire is not, right, and you turn on the water, you can be there for like hours and the fire will not extinguish. So the same thing happens with this.
I'm not a steroid injector in general, because my patient population is usually a preserved articular cartilage, and so and I do a lot of cartilage work in the hip and the knee, and so I'm usually going to Visco or PRP for injections if I do them. But even the hip, it's mostly diagnostic rather than therapeutic, unless, like Jorge said, they have some arthritic changes.
Yeah, makes sense.
Yeah. So now we want to talk about surgical treatment. So there's a couple different surgeries that have been described, PAO classically for true dysplasia, but there's been a push, and you kind of alluded to it, Jorge, with considering isolated arthroscopic surgery for borderline hip dysplasia. So Rob, how do you decide between scope versus PAO versus maybe something combined in a patient that has borderline hip dysplasia?
Yeah, so you think of the shoulder, right? It's your micro instability. Sorry, no micro instability for the hip, but for your multidirectional instability for the shoulder, right? And you have the high Baton score. These are similar patients, that we're talking about for borderline hip dysplasia that become a question mark of what appropriately to do. Like Jorge said, the literature is very clear. A borderline dysplastic patient can be treated very effectively with an arthroscopic surgery and without a PAO. However, the ones that you get concerned about these are your multidirectional instability, shoulder patient types. Sure. The dancers, typically female, not always. High Baton scores, those that have positive signs of microinstability on exam. Those would be the ones that I'd be more concerned about. And like Jorge said, with the fear index that's diverging laterally, then those are the ones that likely be a PAO. If you have a male football player with a 70-degree cam and borderline dysplastic features, which is what I mentioned, no, I'm going to treat that like a CAM patient. That patient's not going to get a PAO. And so those are the considerations. Now, once you get in, for me, you're doing labor repair 98% of the time. And if I can't do a labral repair, then I'm doing labral reconstruction because the hip needs a labrum. Right, that's what I tell patients. I'm really rarely ever, if ever, doing a debridement, and then I'll do a cartilage restoration. And so if they have a full thickness focal condylar defect, that's usually of the acetabular articular cartilage zones like 2, 3, and 4. That's coming right up underneath the acetabular labrum. Then I'll just do a abrasion arthroplasty and then maybe a cartilage restorative procedure there, and then certainly addressing the CAM. But if I have a dysplastic patient that has, like I said, relative retroversion of their acetabulum, I'm certainly not doing, and I'm being very careful with any sort of acetabular osteoplasties that I might consider doing.
Yeah.
I think for hip arthroscopists that don't do PAOs, I think it's important to have a partner that you work with.
Sure.
Yes.
So for those patients that I'm kind of like iffy as to whether they will improve or not with hip arthroscopy, I send them to my partner and say, this is not the time to rush anything. This is the time to take a step back, kind of like look at everything, have multiple opinions. When you have a hammer, everything looks like a nail to you, right? So it's important in those cases to send them to the PAO surgeon, see what he thinks, get opinions from different sides. And then, at that point, you can make a decision with the patient. And there's certainly some other potential issues that may arise from a PAO. The recovery time, it's a much bigger operation, potential complications are higher. So, patients may not like the idea at first, but if it's the right patient, you need to get them the right surgery.
Yeah, I think that is the nice thing about it, that there isn't a rush. This isn't something you have to operate on in 2 days. You can take the time to counsel, get opinions together, seek, counsel from a partner, and I think that's really good advice. And it also, if they are going down the PAO route, it's a big deal. So having that time to sort of let that sit in. Jorge, you were doing a debate later today. Is that correct?
That's correct.
Okay. So your
crushing
debate.
nipple.
I like it. I like the confidence. And that is going to be on the side of soft tissue management. So let's give you the opportunity to practice that debate right now. What are the points?
Very easy.
So am I nipple?
You can
You're on my side. You're on my side.
Let's do a little preview.
I think it's a very easy discussion. There's multiple articles by multiple groups, external validity that has been shown that in the well-selected patient, the borderline dysplastic person, this can work very well. So arthroscopy can be used in isolation for sure. It's just that you need to be careful about the patient selection. Then the second thing that I think it's important is that when capsular management, soft tissue management, and this, as Rob said, I think labrum is important, restoring the suction seal, that gives you stability. If there's insufficient labrum because that patient had another surgery, which is not uncommon in these patients, they have FAI surgery for an instability case, so you have sometimes cases when the labrum is not ideal or suboptimal length or width, and in those cases, a reconstruction may help. So there's patients in which you can see a capsular defect, some others where you don't see that. It's just capsular insufficiency, right, because those capsules are very lax. And what I tell patients usually is when I take the cam, it's like losing some weight, right? So you went from a large shirt to a medium or a small shirt. So you need to placate the capsule to restore the mechanics. That with time sometimes stretches out to some extent. So I can't, it's really difficult to titrate exactly how much tension you need in your capsule. So I tend to go on the stiffer side because with time that will stretch out. So we have patients lay prone after surgery, but we don't want that to be too loose, right? So I think soft tissue management is probably one of the key things to do once you're doing a borderline dysplastic patient.
So Jorge has a great cadaveric example of the suction seal, and I always try to get the video to work in my slides. I can never get it. You got to send it to you. Send it over, and it just exactly. I know it's like Jorge locked it somehow from everybody. So but it just pops right out, and that's that suction seal we're talking about. So for me, I try to preserve native tissue as much as I can. So native labrum. And if they have a hypotrophic labrum, or if they have like a labrum that's everted, you even have like some of these labrums these labra that are everted off of the rim of the acetabulum. I'll actually peel that back. I'll peel that back, and I'll peel down the chondrolabral junction and keep that tissue intact with an arthroscopic elevator. And then I'll do an acetabular osteoplasty again. Being careful if it's a dysplastic patient, and then I'll go back and I'll repair that native tissue. And so I'll really try to preserve that native tissue whenever I can. But if I can't, then you're doing labral reconstruction and circumferential. and trying to restore that suction seal. And there's good data to show that the outcomes are very good in those cases. But I agree with you. As far as the capsule, I'm the same way. I'm pretty much doing what we call like application. So instead of just coming in and using like, it's almost like a scorpion device or whatever, but you coming in and just grabbing it, I'll use our hook devices that are 70 degrees, and I'll take bigger bites of my proximal and my distal capsule and bring that tissue back together. I'm using no fewer than three suture tapes every time, sometimes 4, to get my capsule. And I don't do a T. I'll just do an interportal capsulotomy, and when I'm addressing my cam, and I'll have some traction sutures up, and then I take a proximal portal to do my cam femoral osteoplasty. But even when I'm bringing just that interportal capsulotomy back together, I'm still using 3 to 4 suture tapes.
We're proud to partner with the Unbroken Athlete. Every game, every practice, every moment matters when you're chasing greatness. But peak performance doesn't just happen. It's built.
The Unbroken Athlete helps build it with expert tools to sharpen your mindset, fuel your body with smart nutrition, and recovery from injury like a pro. Because true athletes know what you do off the field is just as important as what you do on it.
And now, whether it's for preventative, performance, or rehab, you can help others build their best too. Join the Unbroken Athlete Affiliate Program and share our programs with your friends, family, and team at a discount while earning a commission when they join. It's a win-win for you and your community.
And don't forget to sign up for the Unbroken Athlete newsletter, packed with the latest research and actionable tips on nutrition, fueling, recovery, mindset, and resilience, delivered right to your inbox.
Visit theunbrokenathlete.com today to join the affiliate program, subscribe to the newsletter, and don't forget to follow along on Instagram at @theunbroken_athlete for even more.
Okay.
Now we want to talk a little bit about post-op recovery after that. So let's say you do soft tissue
They
management.
all do fantastically well.
Wonderful.
Also happy.
For
They're
my
all happy.
patients. So.
Yes. So I know
And the ones that don't, I send to Chicago.
So after, I know people have moved away from bracing after routine hip scopes, right? But if you have a borderline dysplastic patient, you've done soft tissue management alone, are you considering bracing them to kind of get them to stiffen up, or how does your post-op recovery
So
look
it'll be
like?
interesting to see what you say. I do not use braces, and I haven't used any braces in practice because when we came out, the bracing literature was very clear that patients do just as well without braces. I think if they're bulky, they're cumbersome. Have you ever worn personally a hip brace?
Yeah, I did try one on once.
That's exactly right. So I did too, right? It's just like if you wear a Cam Walker boot, for example, you better get the tall boot, not the short boot. The short boot, you're just going to be wobbling around, like even if you're healthy. And so, put these things on and try to see what they do. So for me, the bracing is cumbersome, and the literature is pretty clear that you don't need a brace. So I don't brace anybody. Yeah, but I have my restrictions. So they have range of motion restrictions. I do flat foot weight bearing for the first 10 to 14 days, 2 weeks before they see me, and then I gradually progress them to full weight bearing after that. If I do a cartilage restorative procedure, then I keep them flat foot for 4 weeks, and then I start progressing them after.
I do it a little bit different, so similar on the weight bearing restrictions, but we did this study with Mark Philippon in Vail where we looked at how much would it take for the capsular stitches. I'm not worried about the labrum, to be honest with you. I'm more worried about the capsule because I do a decapsulotomy is pretty large. So if when that tears again, I had one case where a patient fell on black ice and kind of like in the splits and tore it. I mean, it's not subtle. It's not like a labral re-tear where you start to have pain over. It's like massive pain, instability, and it's not good. So that's why I try to use the brace. So we saw that 35 degrees of external rotation and 10 degrees of extension was the limit point between when the sutures get very well stressed, right? So I'm not too worried about normal day-to-day activities, but I'm more worried about when they're not in control, when they're asleep, or they're walking in Chicago. 4 or 5 months in Chicago is not fun, so there's a lot of ice. So if they fall, if they have a brace, they're potentially in a better place than if they wouldn't have it. So for the most part, with normal range of motion, I don't think it's needed. But when you do a big capsulotomy, for the first 2-3 weeks, I think you want to protect it as much as possible for any eventual, things that may happen in the street or somewhere where they're not in control.
Yeah,
And to Jorge's point, that's when for those patients that have had a surgery, whether it's mine or somebody else's, that's where again the MR orthograms afterwards, because really what I'm looking for a capsule, because you're looking for capsular integrity.
Yeah, I think, we've talked about ACL bracing a lot on the show, and, you get a lot of variability, but I think same thing in Denver, you get a lot of ice, you get a lot of snow, and you're really thinking about, okay, if they fall, I'd like a little backup, or it's not unusual. I think the folks of Denver are a little bit more, they want to get out right away and they're a couple days post-op and they want to be at a concert at Red Rocks, and,
Who doesn't?
Yeah,
Right?
exactly.
Are you speaking to how much healthier you guys are in Colorado and
Yes.
active
She
than
does
you
that all
guys
the
are?
time.
Is that what
Yes.
you're saying? It's like,
It's reasonable.
you're the only state. Every time you see the map on health, it's like you guys by yourselves.
Yeah, she's always like, I don't know how it
The
is in
rest
New
of us
Jersey,
unhealthy
but in
people out there.
Colorado,
Yeah,
people
exactly.
I know,
walk.
We're like the rest of us are smoking and drinking and like eating and eating. And
I don't
then,
want to
you
share
know,
the mean BMI of my patients with you.
No. Yeah, no, the anesthesiologists are like, if it's like an ASA level 2, they're like, what's going on?
This is very risky.
You have to go to the hospital.
Exactly.
Okay. So we do want to, start to talk a little bit about when do you choose that PAO. We talked a little bit about sharing with our partners and stuff, but what are the things that sort of, Jorge, make you say, you know what, I want you to see my colleague?
So borderline dysplastic, I had surgery already and failed. Always sees my partner. Anybody that has a positive fear index or a combined antiversion that is higher than normal, and anybody that has generalized laxity, I would have them see them. It has to be a very clear impingement indication for me for a borderline dysplasia, not to send it to him for a second opinion.
Great.
Yeah.
Yeah, no, I'm exactly. I'm the same way. A frank dysplastic. Somebody that has a lateral center angle of 12 or 14. Of course, that's gonna need a PAO. But now I would say that. And the indication is exactly the same for me, but I would say that now we're seeing the combined scope PAOs. And so you're having, and I think you need to do the intra-articular work. So it's not necessarily just the PAO. You want to get in, you want to repair the labrum, you want to assess the articular cartilage, address that as appropriately needed. And I think a lot of us are finding that a hip arthroscopist can do that a lot more efficiently and a lot better than doing it open. And then you can have your PAO colleague come in under the same anesthesia and do the PAO during that setting. Yeah. And some people can do both, like an Andrew Spiker, for example. But others they have a partner that comes in and does it after.
So we want to wrap up with a discussion on return to sports. So we'll focus primarily on the arthroscopic portion, not the PAO portion. So typically, how are you determining that someone is safe to return to sports? Is it time? Are you doing certain tests with physical therapy? Is it a combination? How are you determining that they can get back into sports?
Yeah, multifactorial. And so generally, the general time frame that I'm saying to patients is going to be you're going to get back to running if you're ready, from a strength standpoint and from a symptomatic standpoint, as per your physical therapist, right? Then I'll let you start jogging around 3 months, and then your return to sports is going to be around 5 to 6 months, the general rule. And it's going to be a battery of physical therapy testing, and it's very similar, like we say with the ACL, for example. Is your strength back? Do you have proprioceptive and neuroceptive response to that extremity as compared to the contralateral? And what is your symmetry index as compared to the contralateral as well? And really, a lot of that's being driven by the physical therapist. But that's general. I will say that I had some guy that I did a hip arthroscopy on, and he ran the New York City Marathon 2 months after the surgery. Didn't tell me about it. Comes back in, tells me he ran it, hip's still fine, and then we ended up doing the other hip, and then he was out running, 4 weeks later on the other one. So, and I use that example only to say that these things are possible. That's extraordinarily abnormal, but these things are possible. But no, typically it's going to be about 5 to 6 months return to sport. 5 to 6 weeks, months, 5 to 6 months.
I'd say pretty much the same thing, 4 to 6 months return to sport, depending on how they feel and what type of sports do they do. We've recently started doing more functional assessments on these people because we believe that there's other things besides strength around the hip that's important, such as core activation, glute activation, mechanics, and so forth. And that gives you very objective information they can use to make decisions with their physical therapists and so forth, right? So if your mechanics are still bad, the chances that you re-tear are very high. Remember, it's a dynamic process, right? It's not just having a bump in the bone, right? So as long as they can improve their mechanics, their strength is back to where they need to be, and mentally, which is, I think, something that we disregard fairly often, right? The mental aspect of things and fear of re-injury. I think that's important to address, and once they feel ready, they can go back, but it's generally between 4 to 6 months as well.
Yeah, agree.
That's great.
Yeah, awesome, guys.
Awesome. Thank you so much for joining us today. This was great. As two people who don't do a lot of hip, we learned so much. I can speak for myself.
This is everybody's favorite topic.
Yeah.
It's dysplasia, you know?
Exactly.
Yeah, no, real honor to have you both on.
Yeah.
Good luck at the debate today. We know you're going to win.
Well, now
Go there and cheer for me.
since we prepped him,
Yeah.
now he's ready to go.
Now warmed up.
Confident.
Now warmed
Yeah.
up.
Yes, exactly.
Yeah, love it. Yeah, thank you
Thank you,
guys.
Awesome. Thank you.
All right, thanks.
Thank you for listening to this episode of the Sports Talks podcast. We hope you enjoyed the discussion as much as we did. Make sure to subscribe on Apple Podcasts, Spotify, Amazon Music, and on YouTube to stay up to date on all things sports medicine. If you like what you hear, please consider leaving us a review or comment. You can also reach us by email at thesportstalkpod@gmail.com or find us on Instagram at thesportstalkspod. We love your feedback.